last question.
I think it's very important, the beginning of this talk, that you spoke about how you're trying to balance palliative care and aggressive care and everything. And when I compare that to my experience with my own son, who in the beginning had a glioblastoma, I don't think the family ever understood fully that there was no cure for this. And my own experience in having dealt with it, and the family was not just a caregiver, but the whole family, I mean, and friends and everybody else. My son was very fortunate to have so many people helping him. But I'm very impressed that you have undertaken that study and now find it to be good for the longevity of the patient and also for the well-being of the caregiver. I just think that was marvelous that you presented that, and I thank you.
Thanks. This is actually building off of what you said, sir. But this is for both of you because you both touched on this. But specifically, Deb, I remember you saying that you were doing recordings of people patients, caregivers, and their the doctors speaking, especially when they get an initial diagnosis. And I know there's a lot of feelings about that being a really tough conversation, and obviously it's really traumatic for the people involved. Thinking about receiving that kind of information and the state of mind that you have then, in my own experience, I'm not so sure what everybody else's is, but it's hard to absorb it all. It's hard to know what to say, and then of course you're telling friends, family, whatever. Are there tools or are there models in place for, it seems really silly, but giving out like a fact sheet? I mean, I was thinking about the 3 F's that you were saying, like, here's facts about this diagnosis, here's the feelings you may be having, and here's like, what was a fair request, like, what can you do? Here's some recommended website. If you want to learn more, here's some recommended websites as opposed to Dr. Google. What kind of, because again, the trauma of hearing it, it's hard to know, even if you're recording the conversation, they seem to know it in the moment. What do you remember 5 minutes later, a week later when you're trying to process it?
So that's a huge part. So I think what you said is super valuable. That's a huge part of what I'm really interested in and why I wanted to record these conversations, because you can ask people, what did your doctor tell you? What did you hear? What is your understanding? But we don't know if people what they're taking away from those visits, right? And so what you said is 100% true. So there are some studies that show that the amount of information that people remember from a conversation like that is kind of, the 20 to 40% range, that there's just too much and it's too emotionally charged. And so that is the idea, is that if we could understand it better, and it's not just recording, but the recordings are followed by questionnaires and also interviews later that ask, what did you hear? What did you want to hear? What would have been helpful? What wouldn't have been helpful? And so far, there's one patient that we approached who wanted to do the study and their family said no, but everyone has said yes to being recorded, which is really interesting. And so the idea is that, yes, that you would try to figure out what is the right tool for this population. And sometimes it is as simple as what you said. So there are other studies in other types of cancer where they've done things like question prompts. That is a list of questions that you would get, maybe not at the first visit, maybe you get your information and then it's something that's for the first visit after radiation. Here are some things you might want to discuss with your doctor. And they actually find that those really do shape conversations and help people to get information that they need and to process it. So that's the idea, is to try to figure out where the disconnect is, where's the problem, so that we can figure out if there's something we can do to make it better.
Thank you very much for being here and for all the good work that you do. I'm interested in the question of uncertainty. And in my mind, there are 2 types of uncertainty. And I bring this up because I think uncertainty has a lot to do with anxiety, which is at the root of a lot of problems. There's the kind of uncertainty for which answers are known. It's just that the patient or the caregiver doesn't have those answers, doesn't know where to get them, and you addressed some of that tonight. And I really think hospitals, doctors, and other professionals should have systems in place to be very thorough about trying to provide answers when answers are available. But my question centers on the kind of uncertainty for which there aren't aren't answers. When somebody asks a doctor, well, how long do I have to live? Or how painful is this going to be? Or on and on. I'm guessing that smart people have figured out how to approach, how to deal with that type of uncertainty. You know, we hear stories of people that have crashed a plane in the wilderness and they don't know if they're going to be rescued or not rescued, what to do, should they stay there, should they try to hike out? There are all these uncertainties. Some people can't deal with it and they just give up basically and die. Other people adopt an attitude, nothing's going to defeat me, and often they manage to survive one way or another. I just throw that out as an example of what are the trigger points, what are there should be some methodology in place to deal with uncertainty when in fact it really is true uncertainty. Nobody has the answers, but still we ought to have a system to deal with it. Are you aware of studies or approaches that have been done to address the problem? Sorry for the long question.
No, it's a really good question. So I think this is where I wish that I had my PhD psychology friends here to talk and help to answer the question. But that's where a lot of this kind of methodology for thinking about how you support patients and their families in reducing anxiety comes from, is that there's a lot of work in psychology. And to be fair, some things work better for certain people than for others. Getting at exactly that. So a lot of what we're trying to do is to help people have the tools to be able to manage the uncertainty that's associated with their loved one's illness, because most of it is uncertain. Most of it is uncertain for us. It's very uncertain for the families. It's hard to predict. And so how do you help people be able to live with this situation day after day and cope with that, because you really can't take it away. And there's not an easy fix, but there are these kind of cognitive behavioral things, mindfulness techniques that work for some people. Some people don't like that as much. Cognitive restructuring, the idea that you kind of can change the way that people think about things and the way that they internally talk to themselves about things. But the reality is that there are parts of it that are very hard that we can't take away. The uncertainty, you can't make it go away. There's uncertainty for all of us in life, and you're right, some people do better than others, but sometimes people just don't have the tools because they were never given them. And so talking to someone who knows, how do you think through this problem that you can't fix? And things like, it feels at the time like it helps to go and search online and like you're doing something, but it actually temporarily lowers anxiety and then it comes back even higher. And those things are very well studied. And so those are things that in the hands of somebody who is a skilled counselor, which I am not, you can actually learn to kind of overcome to some degree. Learn to do the parts that are useful and helpful, but to maybe rein it in a little bit so that you're not actually making the situation worse in the face of there being uncertainty. I don't know if you have.
Yeah, no,
thoughts
I
about
think
it.
that's it. And I think us as doctors, we try to be as honest as we can with our patients and recognize that uncertainty, validate that sense of uncertainty, and sort of share that experience with them so they know that we're supporting them as best as we can. I think it's all figuring out ways of helping them through that challenge, which Deb is doing.
Just following on to what you've just been talking about, Atul Gawande has written and lectured widely on this subject. And the issue that I've dealt with him and is about the choice of how to face the fact that you're going to die or your loved one is going to die. And there's a sort of a fork that many patients face, which is, do you want to fight against it with clinical trials? And or do you want to accept what's going to happen to you? And he's, in conversations I've had with him, he's talked about the clinical trials much less positively than you've described them, that most of them don't work. And so that it is a question of whether you want to go through your final days with tubes in you, or whether you want to be relaxed as you can be at home, which is hospice basically. And so is it rage against the coming of the dark, or the alternate path? And that dichotomy in the way he's described dealing with it, I thought was quite remarkable. Now, I've seen it in real time, and maybe the particular experience we had with it was not necessarily characteristic. It is something to consider. I guess that's all I'd say. You may have your own view.
No, I think it's a very good point, and I think it gets to the point that Deb was trying to make with that model that she showed, where, you know, where there's the rectangle with the line going through it with the clinical trials and the palliative care on the bottom side. So they're not necessarily mutually exclusive. We have to figure out a way of getting them both together so that patients can make the right decision for themselves based on the information that they have. And so
They're not quite mutually exclusive, but once you determine to sign up for hospice, you can't have, I'm not sure what you call it, treatment that is
Right.
designed to
cancer-directed therapy.
correct the therapy. You can have
Right.
palliative care,
Right.
not the other. But your diagram was carefully drawn so that there was a sharp line
Right.
between hospice and everything that came before it.
Because for hospice, you can't have any cancer-directed therapy, but that's why I think it's important to have these conversations before you reach that point, where you figure out where that transition works the best for you, and so that we minimize those tubes, we minimize that time in the ICU before passing. So it becomes a much more natural process. And so that's why I think Deb's work is so important, so patients are much more comfortable making that decision to say, you know what, yes, I did as much as I could. I, put my best foot forward. I participated in that clinical trial because it made me feel like I was fighting. Or they say, you know what, that's not for me. I don't want to keep doing that. But that's where focusing on their symptom, on what their goals are, how they want to spend their time, knowing it's not as much time as we would like with that person, how do you figure out, how do you spend that time? And so those are the conversations that we really need to be having. Do you want to go down the clinical trial route? Do you want to spend, the winter in Florida with your family or something like that?
Right,
probably
and
should
with
be-
the trials, what's hard is that a lot of times we don't know. There really is equipoise, and we talk about this a lot. So we don't know. It's unlikely, it has happened before, but unlikely that adding a trial agent or substituting it is going to make things significantly worse in terms of fueling the growth of a tumor. But it might be no better, or maybe it could be better. And a lot of people want to take that risk that maybe this is going to work, maybe it's going to give them more time, even knowing that it's a risk. And then at some point say, like you said, I feel like I've done that. I think that a lot of it is in the communication too, is what is the doctor sort of selling, if you will, to the patient? How are they explaining it? Are they explaining that this is a trial is an experiment? We know that the standard treatment gives benefit, but it's limited. The hope is that this is going to improve on that. And that's the reason we're doing it. Understanding as the provider how toxic this particular treatment is as best as we can, because that's another big thing. Some things are a little bit more burdensome than others, right? And then I always tell people trials are a very, very individual decision. Some people say that's never for me. Some people really want to do it because they feel like it's their way of giving to the community as a whole, to other people going through this, because if no one agrees to do a trial, we'll never figure out what works. Some people don't want to do them at all, but I think a lot of it is in figuring out where the balance is for that individual person. And the problem with brain tumors is that a lot of patients come into the diagnosis already different and not able to adequately say what it is that they would want. And that's a real challenge too. How do you overcome that? Then you have to have these kind of, which these exist, these grassroots efforts to try to get people to talk about these things before they're sick. Try to get people who are otherwise young and healthy and setting out in life to have these conversations so that their loved ones know what they want and they can help make the decisions for them. It's all very complicated.
Thank you both for the two very engaging and enlightening talks. I have two questions. So the first question is on the 5-ALA project with the fluorescent tumor vesicles. And with the ultimate goal, I know you talked about the diagnosis perspective of being able to pull these cells out of the blood and figure out, how much tumor burden is there, is it responding to treatment? But is there a thought to have that sort of the 5-ALA be used in the context of a craniotomy and be able to sort of direct which tissue should be excised and which shouldn't? And then the second question is on the bispecific CAR-Ts. So I was wondering what your thoughts are on the personalized cancer vaccine industry or niche is at this point. And if two antigens are better than one, how do you feel about 20 to 40 neoepitopes, neoantigens? Are these things that could help in the brain tumor world, or is the underlying genetic material, in fact, too heterogeneous to be able to respond to even 40 different neoepitopes at once?
So to answer the first question, which was the 5-ALA question, so that is what it's FDA approved for, is to identify those tumor cells at surgery. So the tumor cells will fluoresce at surgery and the normal tissue won't. So it really maximizes how much the surgeon can get out at the time of surgery. So that's really the indication for the 5-ALA. And the study is really trying to expand on that and use it for an alternate purpose. Your second question about how many antigens should we target is a really difficult one, because yes, a lot of these tumors express a lot of different antigens, but sometimes the antigens overlap with normal tissue. And so you have to be very careful about what antigens you target. And, the idea, we don't know what is the optimum number of antigens to target. We don't even know which specific antigens to target. The hope, and one of the hopes with the BiTE therapy, is that if you can activate the immune system by sort of targeting one or a few antigens, you can rev up the immune system so that then it becomes active in fighting the cancer and recognizing the cancer as foreign. And so maybe you don't need to target 40 antigens, maybe you can target a fewer number of them as long as you wake up the immune system. In brain cancer, it hasn't been, they've been doing neovax studies for a little while now. They've been pretty toxic. The results have been very mixed. And so I still think we have a lot to learn along that route. But it's really finding that right target and the number of targets. So I'm not sure I have a good answer to your question.
So do you see benefit conjugating the neoantigens with, for example, a checkpoint inhibitor, some other immunotherapy?
So that's sort of where these things are moving, is to try to combine them with checkpoint inhibitors. Checkpoint inhibitors are a way of removing the brake on the immune system. And so if you combine a vaccine with something that will release the brake on the immune system, then you would increase the immune system response to the tumor. And so that's where people are moving towards, and that's going to be sort of the next phase of treatments and trials.
Sorry, I'm going to double dip here. When you talked about caregivers, I automatically thought in terms of family and close friends or something. But of course, doctors are caregivers. And I would be curious to know how you, as doctors, deal with the problem that you're in a business where a large percentage of your patients are frankly going to die. That must have an effect on you. And one way that I imagine doctors deal with it is to sort of objectify the patients, not get too personally involved with them. And when I think about it, my primary care physician, I don't think he knows what I do for a job. He certainly doesn't know what my hobbies are. He really doesn't know anything personally about me. It's all business when I'm in there. And maybe there isn't time for all of that. But so my question is, how do you as doctors deal with this? And what's the balance that should be struck between being personally involved with a patient, showing that you care, but also protecting yourself from not being devastated when you lose a patient.
It's not easy.
I think you have to have a special personality to go into this, and I think you have to derive reward from different aspects of caring for patients. And so being able to get a patient through a challenging time. I know what the endpoint is going to be, unfortunately, but if I can make that journey a little bit easier, then I feel like I have done a good job. I've helped somebody. And then if I can combine that with the research aspect of it, so that I know that maybe I can help the next patient down the road. You really have to derive that sense of reward of helping other people out of the job to keep it sustainable. And working with amazing colleagues who are all working together towards a common goal, I think really makes it sustainable. You meet such amazing people who are faced with a really challenging disease, and seeing how they cope with that, how they get through those tough times, it's very inspiring to me on a day-to-day level. Is that sort of my challenges of trying to get my kids ready for school is nothing compared to what some of my patients are going through, and it's just rewarding to see people rise to the occasion.
I think so too. I went in early in my fellowship. I went to Dr. Tracy Batchelor, who's on the handouts that are here, although he now has moved on to be the head of all of neurology at Brigham and Women's, so he's not our immediate chief anymore, but he was the head of the Brain Tumor Center at the time. And I went to him in his office and I said, how do you stop feeling sad about all of these sad losses? How do you stop feeling upset about these things that you're seeing every single day? And he said, and I'll never forget, he said, do you want to not feel sad about things that are sad? Because then I would be more worried about you if you weren't upset by these things. So I think that Elizabeth's right, that people in this field in particular go into it because they enjoy making connections with people. They want to have those connections with patients and families, and that the loss is a necessary part of it. But if you go into it knowing that, then it's okay to sometimes be sad. I think what every individual person has to feel out for themselves is how do you have that piece and then also find the things that make it feel like you're doing something that is meaningful despite those losses that will happen. I don't think it's easy. I think for me, it's been very important to have colleagues that I could go and talk to. But I think a lot of people are thinking about this right now. A lot of people are thinking about this idea of physician burnout, where doctors just can't emotionally, it's sort of an emotional, psychological thing. They can't handle it anymore. And one of the correlates, predictors of burnout, one of the things that's associated is if people do become detached, if they do become where it gets kind of depersonalized, that's actually far worse. That's kind of a really bad sign that you're not in a good place if you're in that way. So I think some people do it that way. I think it would be very hard to be in this field because you're just involved. You know what most people do for their jobs, but you have the luxury of having more time than a primary care doctor who only has 7 minutes or 10 minutes, and we have 30 minutes or an hour. And so it's a little bit different because it's also kind of structured differently.